Magnetic resonance elastography is a quantitative technique for imaging the mechanical properties of tissue. Its main current application is assessing liver fibrosis. It's been available commercially as an upgrade for conventional MRI scanners since 2009 and is now widely available from at least 3 MRI manufacturers. It's a quick procedure with an acquisition time of about 1 minute. Many diseases affect tissue stiffness in a profound way, and that's the basis for the diagnostic usefulness of palpation as a clinical examination technique. Conditions like malignancy and fibrosis increase tissue stiffness, often quite markedly, and other diseases decrease tissue stiffness. Magnetic resonance elastography works on the principle that propagating mechanical waves move more rapidly in stiff material than in soft material. The basic idea is to generate mechanical waves in the body and to track the waves as they pass through various structures. If you could measure the speed of the wave in various regions, it would reflect the local mechanical properties. And if you were to apply continuous waves, like you see here, then the speed is reflected as the wavelength, which is longer in stiffer areas and shorter in softer materials. The challenge for making this work is that propagating mechanical waves only move the tissue by a few microns at most, and this is far below the spatial resolution of conventional imaging techniques. The advance that made MRE possible was the discovery of a way to use a special MRI technique to directly image mechanical waves deep in the body with amplitudes as small as the wavelength of light. This is a conventional MR image of a tissue-like gel object with 2 stiffer inclusions inside, as shown by the arrows. The first step in MR elastography is to generate mechanical waves inside the tissue, typically by using a source of vibrations at the surface. The frequency is in the low audio range, typically around 60 Hz. A special MRI sequence with cyclic motion encoding gradients is then used to acquire multiple snapshots of the propagating waves, which you see here. The waves move more rapidly through the stiffer inclusions. Notice that the motion is very small here, only a few microns, and yet we see it very well. This acquisition takes only a few seconds. In the final step, the scanner automatically processes the wave images using a special algorithm to create a final image that quantitatively shows the stiffness of materials in this cross-section. You can see that the inclusions have a stiffness of about 50 kilopascals, whereas the surrounding material is around 20 kilopascals, quite a bit softer. Chronic liver disease is a very common cause of death worldwide. Many conditions can cause acute liver injury, and many of these conditions eventually lead to the common endpoint of fibrosis, progressive scarring, and cirrhosis of the liver. There is an increasing prevalence of conditions that cause hepatic fibrosis. Chronic hepatitis C affects nearly 200 million people around the world, and chronic hepatitis B is also a very common disease, especially in Asia. And in North America and Western countries, we have an epidemic of obesity and fatty liver disease now affecting about 1 in 3 people in the United States. The important thing is that progressive hepatic fibrosis is often clinically silent, but it can often be halted and in some cases even reversed if it's diagnosed early and treated appropriately. So we would like to detect hepatic fibrosis, which typically doesn't cause anatomic change in the liver, before it progresses to irreversible cirrhosis. Cirrhotic liver not only has a high mortality, but it's also a pre-malignant condition, leading to the development of primary liver cancer. For many years, the standard method for diagnosing liver fibrosis has been a liver biopsy. It's a well-established technique and sometimes called a gold standard. But it's invasive and it's associated with pain and complications. About 1 in 100 patients who has a liver biopsy has to be hospitalized for complications, and unfortunately about 1 in every 10,000 patients will die from complications of a liver biopsy. Another significant issue with biopsy is the problem of sampling error. Here you see two parts from the same liver biopsy specimen. The lower one shows advanced fibrosis and the upper one shows almost no fibrosis at all. There's also a substantial amount of variability in the reported stage of fibrosis when the same specimen is assessed by different analysts. So why would we think of using a technique that measures tissue stiffness to assess the presence of fibrosis? Well, we know that the normal liver is one of the softest tissues in the body, whereas physicians can sometimes palpate a cirrhotic liver as a rock-hard structure in the upper abdomen. So that must mean that between these two extremes the liver must stiffen as the fibrosis develops, and this is the basic idea behind using a technique for assessing stiffness to diagnose liver fibrosis. MRE is performed by placing a special device for generating vibrations over the liver. This creates propagating mechanical waves in the liver. It's not uncomfortable. The scanner then acquires images of these propagating waves over a period of about 1 minute. The scanner then processes the wave information to generate cross-sectional images showing the stiffness of tissues as you see here. Here are conventional MR images of two patients who have known chronic liver disease. The question is liver fibrosis present? We know that liver fibrosis doesn't usually cause anatomic changes until it's very advanced. So in these two patients, it is very difficult to say whether one or the other is developing liver fibrosis. Here are the elastograms, and you can see that this patient has a normal liver stiffness of about 2.2 kilopascals, whereas this patient has a very stiff liver, nearly 3 times normal, and biopsy proved that the patient has advanced fibrosis. Currently, magnetic resonance elastography is most often used as an add-on to a standard abdominal MRI exam. And this is a timeline diagram showing a typical abdominal MRI exam, showing various types of imaging techniques that are used over the 30-minute or so duration of the exam. MRE only requires a short acquisition time, so adding it has little or no impact to the total length of the exam. Now, if you don't need a full abdominal MRI and you only want the MRE, you could do an exam that could be done very quickly. It might be combined with techniques that are now available for assessing liver fat and iron. You could call this type of very rapid exam a hepatogram, for instance. It only requires about 2 minutes of total imaging time, and it provides a lot of quantitative information about liver health. Quantitative measurements of fat, an estimate of iron content, and of course evaluating fibrosis and inflammation. Because it only requires a few minutes of magnet time, this type of exam could have a very modest cost. This slide shows examples of patients with various stages of liver fibrosis, ranging from no fibrosis to stage 1, stage 2, stage 3, and stage 4. I'm showing the wave images on top here so you can see how the patients with the most advanced fibrosis have longer wavelengths. And this, of course, is reflected in the elastograms in the lower row. Normal liver tissue has a stiffness of about 2 kilopascals, whereas cirrhotic liver may have a stiffness of 5, 10, or even 20 kilopascals. Many studies have now been done comparing biopsy staging with liver stiffness assessed with MRE elastography. Here's a summary of stiffness values in 438 patients who had biopsies to assess liver fibrosis. There is a progressive increase in liver stiffness with increasing fibrosis stage. This makes it possible to use the stiffness value as a way of estimating the fibrosis stage. A number of studies have been published examining the diagnostic performance of MRE elastography in assessing fibrosis. This figure will summarize a meta-analysis that was published in 2012. The authors compiled the results of multiple published studies assessing the performance of MRE in diagnosing fibrosis of stage 1 or greater, stage 2 or greater, stage 3 or greater, and stage 4 or greater. Just for comparison, I'm going to show you here the reported diagnostic performance of a common clinical metric, the AST to platelet ratio index. That index, which is a laboratory-based test and then a calculation, has better diagnostic performance for detecting higher stages of liver fibrosis, where the effect is most severe, but it's got poor performance at earlier stages. What does this scale at the side mean? Well, a value of 0.5 means that the test is worthless, no better than a coin flip, and a value of 1 means that the test is 100% accurate. So here's what they found for MRE elastography in this aggregate meta-analysis. Very high diagnostic performance for diagnosing all levels of liver fibrosis. They concluded, based on this study, that MRE is an accurate, non-invasive method of staging liver fibrosis. This is another meta-analysis review that was published more recently. It was a little more elaborate in that it actually involved looking at the primary data in each of the studies that were included. They concluded, based on this study, that MRE has a high accuracy for diagnosing significant or advanced fibrosis or cirrhosis. And here is yet another study that was recently published in 2014 that looked at patients with non-alcoholic fatty liver disease. It was a prospective study comparing MRE and biopsy. They concluded that MRE is accurate in predicting advanced fibrosis and may be used for non-invasively diagnosing advanced fibrosis in patients with non-alcoholic fatty liver disease. MRE elastography has been in clinical use at the Mayo Clinic since February in 2007, and it's been used in more than 5,000 examinations to date. The most common indication for using MRE has been fatty liver disease. This condition is associated with obesity and diabetes, and it now affects about 1 in 3 people in the U.S. There is a spectrum of disease. Most people who have this condition have simple steatosis, simple fatty change in the liver with no complication. But a minority of people who have this condition develop inflammation and chronic liver injury that eventually can progress to liver fibrosis and eventually even cirrhosis. So this is a serious condition because it's so common. And in fact, it's been predicted that fatty liver disease-induced liver failure will become the most common indication for liver transplantation in the U.S. These conventional MR images show 2 patients with fatty liver disease. Typically, there's no anatomic abnormality with hepatic fibrosis, so you just can't tell if either of these patients is getting into trouble with fatty liver disease. The elastograms of these patients are very different. This patient has normal liver stiffness around 2 kilopascals and has no fibrosis, and this was proven with biopsy. This patient, on the other hand, who also had normal anatomy, has very high liver stiffness, and a biopsy showed stage 3 fibrosis. Here is another example of 3 patients with known fatty liver disease. There is no anatomic abnormality here, so you can't tell from conventional imaging whether any of these patients is getting into trouble with progressive fibrosis. This patient has normal liver stiffness, as you can see. This patient also has normal liver stiffness. This patient, on the other hand, has markedly increased liver stiffness consistent with advanced fibrosis, and yet the liver anatomically is normal in appearance. Steatosis alone doesn't seem to affect liver stiffness, and that's fortunate. In the early studies of MR elastography, many of us were concerned that perhaps the presence of fatty change in the liver would make the liver softer, perhaps canceling out the effect of any fibrosis that was present. Well, it turns out that the presence of fat in liver cells seems to have no strong impact on liver stiffness. This diagram shows a series of patients with various stages of liver fibrosis, which you can see in the color scale on the side. And what we're showing here is the fat fraction on the horizontal axis and the stiffness on the vertical axis. To simplify this, I'm going to remove the middle stages of liver fibrosis, and we'll just look at patients who have no history of liver disease and patients who have advanced fibrosis. You can see that in patients with advanced disease, there's no relationship between liver stiffness and fat fraction, which ranges here from 0 to nearly 12% or so. Similarly, in patients who have no history of liver disease, shown in blue here, there's a wide range of fat fractions, but there's no correlation with liver stiffness. How early can we demonstrate the complication of NASH in patients with fatty liver disease? Here's a study that was published in 2011, and I'm showing you here a few examples of patients that were included in that study. At the top here are the anatomic images. And then here are the elastograms, and in the lower part of this slide you can see the biopsy results for fibrosis stage and inflammation grade for each of these patients that's shown. Let's first look at patients on the left who had normal liver stiffness values of around 2 kilopascals. And you can see that the biopsy results here, as expected, showed no fibrosis and no inflammation. On the right, you have two patients who have very high liver stiffness, 10 kilopascals and 7 kilopascals respectively. And in the biopsy, we can see that there was advanced fibrosis, stage 4, and the presence of inflammation. In the middle, we can see two patients who had elevated liver stiffness at 4.4 kilopascals and 3.6 kilopascals. The biopsy showed that there was no fibrosis, but there was inflammation consistent with the presence of steatohepatitis. So here we're detecting the development of NASH, the dreaded complication of fatty liver disease, with an elevated liver stiffness even before the onset of liver fibrosis by biopsy. Chronic hepatitis C infection is another common cause of liver fibrosis. There are about 5 million people in the U.S. who have chronic hepatitis C infection, and about a quarter of these patients will develop progressive liver fibrosis. We now have very effective drugs to treat chronic hepatitis C infection, but the treatment is often reserved for patients who are developing significant fibrosis. In the past, a biopsy was needed to make that determination. Now we have an alternative, and in this patient, MRE revealed an unexpectedly advanced disease. This patient went on to have treatment without having to have a liver biopsy. MRE elastography can be used to assess the response of liver fibrosis to treatment. This is a patient who has chronic hepatitis C infection and who started treatment in 2009. At the beginning of the treatment, the stiffness of the liver was about 4.2 kilopascals. And here, in 2012, after treatment, the liver stiffness has decreased almost into the normal range at 2.8 kilopascals, showing a good response to therapy. This is a 76-year-old patient with a long history of excess alcohol consumption. At the time of this examination, the stiffness of the liver was markedly elevated at about 5.5 kilopascals. After this examination, the patient undertook to abstain from alcohol. We had an opportunity to re-examine the patient 9 months later, and in this examination, after being abstinent for 9 months, you can see that the liver stiffness has decreased substantially to 3.4 kilopascals, a very gratifying result. Here is a patient with autoimmune hepatitis. This is a very treatable form of chronic liver disease. In 2007, prior to treatment, the liver stiffness was markedly elevated at 4.4 kilopascals. This patient had a liver biopsy that showed stage 2 fibrosis. Here, after 22 months of treatment with corticosteroids, the liver stiffness has markedly decreased to 2.9 kilopascals, and interestingly enough, the liver biopsy was reported as showing no evidence of fibrosis. Like conventional MRI, conventional ultrasound is not capable of assessing the property that we call tissue stiffness. But over the last few years, ultrasound-based techniques have been developed to quantitatively measure the stiffness of tissue. The best-known ultrasound-based technique is called Transient elastography, and it uses a device that generates mechanical waves in tissue, and then these waves are tracked using speckle tracking ultrasound to measure the speed of the wave. The stiffness of tissue is then calculated from the wave speed. The diagnostic performance of ultrasound-based elastography has been compared to MRE elastography in a number of studies. This study was published in 2008 and was done in Belgium. It involved 141 patients who underwent both MRE elastography and ultrasound-based elastography or FibroScan. Here's the same diagram that I showed earlier showing the performance for different stages of fibrosis from stage 1 to stage 4. And here's what this study found for the diagnostic performance of FibroScan. As you would expect, the diagnostic performance is highest with the most severe disease. And here is the performance that they found with magnetic resonance elastography, much higher diagnostic performance. And in addition, they also noted that the rate of technical failure was lower with magnetic resonance elastography, about 6%, versus about 16% with ultrasound-based elastography. How can we understand these results? Well, let's start with liver biopsy and its limitations. Liver biopsy assesses the condition of the liver using a tiny specimen that's only about 1/10,000th of the volume of the liver. This has obvious potential for sampling error since fibrosis is often quite heterogeneous in the liver. Ultrasound-based elastography typically assesses liver stiffness at a spot located about 6 centimeters below the skin surface, and it's usually reported at 10 locations in the liver. So this is a much larger sample than with biopsy, but it's still only about 1/2000th of the volume of the liver. MRE elastography, on the other hand, provides a cross-section of the liver showing the stiffness quantitatively over a relatively large region. You can image a few sections or you can image the entire volume of the liver with this technique. So a much larger volume of the liver is assessed. Even in one section, you can see in this particular example how if you measure the stiffness with a biopsy or ultrasound at this location, you would conclude that the patient has very advanced liver disease, whereas at this location, if you biopsied or measured it with ultrasound, the stiffness of the liver would indicate that the patient probably has very little fibrosis. We know quite a bit about the repeatability of MR elastography. Repeatability is important because if you make a measurement to assess a patient at one time and then assess them later, you'd like to know that if there's a change in liver stiffness, it's due to a change in the actual condition of the liver and not just variability of the measurement itself. This study was published in 2011. Patients or volunteers were imaged twice during one visit and then brought back 2 weeks later and imaged twice again. These repeated measurements of the same area of the liver were then compared, and they were found to be highly repeatable. A consensus conference was held by the Society of Radiologists and Ultrasound in 2014, and they reviewed the diagnostic performance of ultrasound-based elastography and MR elastography in assessing liver fibrosis. They concluded that among the non-invasive techniques, MR elastography is the most comparable in accuracy to adequate biopsy in diagnosing liver fibrosis. Unlike other quantitative MR procedures, the FDA cleared implementations of MRE from 3 different manufacturers have many common features. They all use the same driver hardware, processing technique. They all report the same quantity, which is the magnitude of the complex shear modulus. They all use the same standard driving frequency of 60 Hz, and they use the same type of display and color scale and display defaults. They also all have the same type of overlay showing where measurements are most valid. Investigators are now looking into many other applications of MR elastography. Those would include assessing breast cancer, kidney disease, prostate cancer, assessing the pancreas, the heart, and the lungs. At this time, it seems most likely that the next widely accepted application of MRE will be for brain imaging, particularly for preoperative planning in patients who have brain tumors, especially tumors like meningiomas and skull-based tumors. So just before we wrap this up, here's an example of the patient impact. This is an example of a young woman who has severe psoriasis. It's controlled effectively with methotrexate therapy, but methotrexate is known to cause liver inflammation and fibrosis in some patients. So for the last 15 years, this patient has had to have a liver biopsy every 2 years just to confirm that she's not developing liver damage. We now have a non-invasive technique to offer her. Her MR elastography shows that her liver stiffness is normal at 2.1 kilopascals, so she has no evidence of liver fibrosis. She's avoided the discomfort and expense of a liver biopsy, and she'll be followed this way in the future. So in conclusion, there's now good published evidence that MR elastography is a reliable non-invasive method for diagnosing liver fibrosis. And in that role, it's safer, more comfortable, and less expensive than liver biopsy. And there are still many other applications to explore. Thank you.